thank you everyone for joining us tonight for our latest webinar. It has been a little while since our last one. If you've been with us before, thank you very much for joining us again, and you know how the webinars work. If you've not joined us before, then the webinar probably lasts about an hour, just over an hour. It's about 45-50 minutes, and then there'll be time at the end for questions. If you have any questions throughout the talk, then please use the Q&A box at the bottom of the screen. Type your questions in there, and at the end I will then present the questions to our guest speaker. There is one CPD point interactive available for optometrists and dispensing opticians, and that is if you are watching it live via the link, which is quite important because Zoom records who's logged on, and I can then use that information to get the certificates out. And the certificates are aimed to get out next week. I have 10 days to get the certificates out, and I'm away this weekend, so it will be next week, hopefully. But the webinar is being recorded, and hopefully with the permission of our speaker, we'll put on our YouTube site, but depending on how it goes. So thank you very much again for joining us. So a little bit about tonight. We've not got our usual speakers that run the group tonight. We've got a guest speaker, which is fantastic, and a little bit of a different topic because we've not had a glaucoma talk before. It's normally medical retina talks and things like that we've had. So our guest speaker tonight, who's taken her time out to join us, is Miss Sally Ameen, and she completed her preclinical medical school training at St Andrews University in Scotland, achieving distinction at BSc level. She then transferred to St George's Medical School in London, where she graduated with a degree of merit. After her foundation training, she entered the ophthalmology run-through training in the Northwest London Deanery and trained at the main ophthalmology teaching hospitals, namely Moorfields Eye Hospital and the Western Eye Hospital. Ms. Ameen chose to subspecialise in glaucoma and successfully completed her final training in this field and went on to her current substantive consultant post at the Western Eye Hospital. Ms. Ameen has presented at a number of national and international meetings and published 2 book chapters and a number of other papers in peer-reviewed journals. So tonight, Ms. Ameen will discuss the latest developments in glaucoma. So I would like to hand over to you. Thank you very much.
Thank you, Ian. That's brought back some memories. I mean, this is going way back now with regards to graduation, but thank you so much. I will start by sharing my screen, if that's okay. And then I hope everyone can see this, and hopefully it's nice and clear. So the title of the talk today is the changes of practice when it comes to glaucoma, from diagnosis to treatment. So the aims of objectives, I just wanted to start off by outlining what glaucoma is and the subtypes, update when it comes to development of diagnosing the patient, as well as the treatment options that are currently in the market and in the pipeline. So I'm sure many of you know this already, so please excuse if it's all very basic. But as you know, glaucoma is a kind of a generic title that covers a wide range of conditions. The main characteristic being the progressive optic neuropathy or loss of nerve fiber tissue with a corresponding visual field defect, and that may or may not be associated with the rise of intraocular pressure. It is the commonest cause of irreversible blindness in the world, and as the picture shows below, the disease tends to progress where you lose the retinal nerve fiber layer at the optic nerve head and you get severe cupping, and with that progressive visual field loss that usually starts with the tunnel vision and ultimately can cause to, like I said, irreversible cause of blindness. So that's why there's a massive big push to try and identify and diagnose patients early, commence treatment early, and stop or halt any disease progression. How does it manifest for the patient's point of view? Well, as you recall, with the optic nerve head, everything is back to front and upside down. So the inferior rim would supply the superior visual field and the temporal supplies the nasal, and so on and so forth. And this is a very classic appearance of what happens with optic nerve cupping once it reaches a stage of visual field loss. So the peripheral visual field gets affected as it goes around, and then ultimately, unfortunately, it can lead to complete blindness. Now, phenotyping, when we are trying to describe these cases, you can classify them either depending on the anatomy. So is it an open angle glaucoma or an angle closure glaucoma or closed angle, and if it's primary or secondary. The commonest type of glaucoma is primary open angle glaucoma, where essentially you have a rise of intraocular pressure with applanation tonometry, so that being over 24 millimeters of mercury, with no other signs or identifiable features. So the angle is wide open, there's no other deposits and stuff. The secondary alludes to things like, or conditions like, pigment dispersion glaucoma or pseudoexfoliative glaucoma, where the angle is open, but there's sedimentary material sitting in the angle that leads to the closure. The angle closure or the closed angle glaucoma, again, primary or secondary, primary being anatomically a short eye with a shallow anterior chamber and a small drainage angle that then can close and essentially obstructs the flow and causes pressure to go up. Or secondary, where the actual closure is secondary to something else. So either, for example, patients who've had retinal surgery and have oil, and that's what's clogging up the angle, or phacomorphic, when the cataract grows and it causes closure, that kind of thing. The only current cause that can be controlled is pressure. We know it is not the only cause of glaucoma. Genetics plays a massive part, as well as circulation, especially in conditions like normal pressure glaucoma, but the intraocular pressure remains the only variable that can be controlled. All the treatment modalities that we have, whether it's the drops, laser, or surgery that we'll go on to cover, work on very two simple principles. And it's either reducing the pressure by reducing aqueous production or increasing outflow. So the way I describe it to the patient is I normally draw up this picture that you have just there. The fluid, as you know, gets produced by the ciliary body, goes through the pupil. 75% of it goes through the conventional pathway, which is through the trabecular meshwork, and 25% gets absorbed through the uveal scleral pathway. That's the natural clearance process. All the medication that we use either work on turning off the tap, which is essentially affecting the ciliary body, or working on the plug hole, which is either the uveal scleral pathway, the standard conventional pathway, or creating a brand new pathway altogether in the surgical option that we'll want to cover. Now, this is a question that gets asked over and over again, which is why I thought we should touch on it here. This is actually an old model from an old book, because we don't use these things anymore. A patient always asks, well, what's normal pressure? And really, ultimately, what this very, very clever graph looks at, normal pressure is at a pressure at which there is no evidence of progression. Sorry, not normal pressure, but target pressure would be the pressure at which there is no progression of the optic nerve disease. Now, you can look at this clever calculation, and essentially what you're looking at is the opening pressure plus the rate of progression and any factors that can increase the risk of that progression. So that is IOP fluctuation, life expectancy, having other conditions such as pigment dispersion syndrome or PXF, corneal thickness, family history, so on and so forth. You can see it in the graph at the bottom. But ultimately, what you're aiming for is a pressure at which the disease stops from progressing. And it's a very personal number to every single patient that you have in front of you. I'm sure you've all seen patients with pressures in the 20s and sometimes even 30, where the nerve is healthy, whereas we have patients whose pressures are 15 or 16 and unfortunately still show evidence of progression. So it's a very personal number, and we tend to try and work it out by looking at the opening pressure, so the pressure at presentation, and any other risk factor that increases the risk of progression. And unfortunately, the more risks you have, the lower the target IOP, the more aggressive treatment modality. So what is the ultimate objective when we are treating these patients? So you have to remember the most important thing with these patients when they come to you is they are absolutely fine in most cases. So they are completely asymptomatic most of the time with very good, excellent 6/6 vision, and they end up coming to either yourselves or the hospital setting where we're now shoving lots and lots of medications at them. That's making the situation worse and worse from their point of view. The biggest target that we are now focusing on is essentially quality of life. So essentially maintaining the quality of the life of patients as well as the quality of the vision. Cost has to play a factor when it comes to treating these patients. And it's not just the cost of the treatment, but it's the overall cost to the health service if, God forbid, this patient is not treated appropriately and they end up losing vision and become dependent. So the main aim is to maintain the visual function and quality of life at a sustainable cost. So that's led to a drive to change in terms of how we diagnose these patients, as well as the treatment options that we have available. The other drives have also been the increased number of patients. It's an aging disease, so we have more and more patients with glaucoma every year who are living longer and longer. The life expectancy is longer. There is increased awareness of the conditions, and the patient's expectations are also higher. Something that they may have been happy to tolerate 15 to 20 years ago is definitely not the case today. And the clinicians and the patients have these high expectations. COVID-19, as evident of the talk today, has forced us to think outside the box when it came to treating these patients and trying to do it safely without overexposure. So what happens when it comes to diagnosis? So obviously the hallmarks that we're looking for is optic nerve change with a corresponding visual field defect. Again, going back 10 to 15 years, I'm sure a lot of you have seen pictures of discs, circles being drawn, and there's been lots of studies have shown that there is inconsistency of subjective measurement of the optic nerve cup disc ratio. So we have definitely moved over more objective measures, namely being the OCT, or ocular coherence topography, which is essentially like an ultrasound light frequency that measures the nerve fiber layer and gives an objective value of that nerve fiber layer. Now, OCT by itself can be a big talk just to look at, the pros and the cons, the pluses and minuses, and how useful is it as a tool. In reality, it's still in its infancy, in the sense that we have a number of machines that are still being tweaked to get more objective and better measures. But essentially what you're looking for is progression. So very rarely do you have a patient at the first point of presentation where you have completely normal healthy disc on OCT or completely abnormal healthy disc that you can say to them, yes, you don't have glaucoma, or no, you definitely have glaucoma. About 85 to 90% fall in that gray area where they're not picture perfect. So you get these funny colors, which essentially allude to the fact that there may be some defect in the nerve fiber layer, and it tells you the distribution of where that might be. And essentially what you're looking for is progression. So if there is nothing else that alludes to the fact that this patient has glaucoma, i.e. the visual field is absolutely fine, the pressure is absolutely fine, and there's nothing else that you can see on your examination, then these patients tend to be observed without any treatment. And then the beauty is you have this nice objective picture, you repeat it in 4 to 6 months time and compare it to itself, and you look for change. So that's how this is still very useful as a tool. The other use of OCT is to look at the anterior chamber. So you've got anterior chamber OCT that can appreciate the angle and can give you a definition again of open versus closed. It's not dynamic, so as you know, it doesn't take away from actual direct gonioscopy that still needs to be performed to give you a better idea about the angle structure, the iris insertion, any other abnormalities like peripheral anterior synechiae, adhesions, so on and so forth. But it's still a work in progress, and I think with time will become more important when it comes to diagnosis. And finally, the thing that we all do, the thing that all patients hate, which is a visual field. But ultimately, this is what it's all about, because this is what we are trying to preserve, a healthy visual field. Just going back a bit, casting your mind back when it comes to optic disc changes, you would need to lose about 50% of the nerve fiber layer before you develop a visual field defect. And the ultimate game and the ultimate aim with all these new toys that we have is we pick up what's called perimetric glaucoma. So identifying change and documenting progression before it causes a visual field defect, so we can treat these patients and maintain their full visual field for as long as possible. So then when it comes to monitoring, like I said, you have a serial disc OCT scan that you can look at, and you have progressive analysis that looks at and tells you, well, has this disc progressed over time or has it not? And the visual field, and like that applies for the disc, like I said, as well as the anterior chamber scan. So with this one, with picture A, you can see the patient was still phakic. It's a very narrow angle, probably closed on this side, and post-surgery, wide open, anterior chamber. You can actually even make out the wound incisions there from the cataract operation. The visual field is still there. The future would be OCT prediction and mapping of visual field defects. There is a lot of algorithm being designed at the moment to try and to get the machines to speak to each other, to see if we can marry up the visual field changes with the disc OCT changes. So you have to remember, with the visual field, it is very patient reliant. So you need reliable patients who can perform the test very well, whereas the measures with the OCT, whether it's anterior segment or the disc OCT, yes, they are operator dependent, but they are objective from the patient. So it doesn't require patient's involvement. So, for instance, say you have some changes on the disc OCT and you have a funny looking visual field. If you can have the analyzer that can marry up the two images and says to you, actually, that visual field has not been caused by that disc OCT, then you can put it down to the fact that it's probably more the fact that the patient hasn't done the visual field appropriately, and so on and so forth. So going forward, that will definitely be very useful. So the future of monitoring. We have already moved over to the virtual clinics. I'm sure many of you have been involved in this, and essentially it's when the patient comes in, has all the investigations done, so their vision, their intraocular pressures either done by eye care, or in some instances actually a Goldman tonometer, visual field as well as an OCT. Everything's loaded up onto an electronic platform. Some people use Medisoft, some people use Medisight, some people use Open Eyes, and the data is interpreted by a clinician. There is a lot of outsourcing of these stable patients into their local units, namely their local optometrists, because pretty much you guys have all the kit that's available within a hospital setting, and therefore can run the same things if you have a safe and stable platform onto which the data can be uploaded and interpreted. There's also a move towards mobile units. So instead of being one set fixed location, you can have something like an eye van. So a bit like the mobile CT and MRI scans, you have a van that has a visual field machine, an OCT machine that travels from unit to unit to do all this kind of imaging. Now, just because the topic is very current at the moment, AI is going to play a very big part when it comes to interpreting the results of these investigations in the future. We've already seen the experimental work when it comes to medical retina and the interpreting of macular OCTs. It will definitely play a role when it comes to glaucoma diagnosing, monitoring, and further input. So definitely watch this space. So if we move over to the treatment of patients, so say a patient has presented to the clinic, have been diagnosed with either ocular hypertension, where the pressure in the eye is considered above normal, but essentially the disc is healthy and the visual field is full, or primary open-angle glaucoma, so raised pressure with disc damage, hopefully before having a visual field defect. So the treatment recommendation has changed over the last, I think, about 18 months, secondary to this trial, which is the last light trial that was carried out at Moorfield by Professor Goss-Guzzard. And essentially what it looked like, it's comparison SLT or selective laser trabeculoplasty versus conventional treatment, which is prostaglandin analog. What I actually was looking at is quality of life, but also as secondary measure was IOP reduction. It did show that the SLT was as effective as the prostaglandin analog with lower cost, both to the patient as well as the health service, because obviously you're not prescribing all these medications. Surprisingly, the quality of life wasn't different between the two groups, but based on that, NICE has changed its recommendation and as a first-line treatment for patients who have OHT or POAG for it to be SLT unless there is a contraindication. I think one of the ones they highlighted being pigment dispersion, and we can touch on that. And I just thought it would be interesting for you guys to see a video of what SLT actually looks like. So normally at the moment is being done by gonioscopy. So it's on a machine just like a slit lamp, if many have seen it, topical medication onto the eye, use any kind of specific lens that shows the drainage angle. Different people prefer different lenses. The size of the laser spot is preset, and as you can see, you get these what's called the champagne bubbles, which shows basically minimal reaction. So there's actually not much of tissue reaction that you can see, but the idea behind it is it just causes a low degree of inflammation to encourage macrophages to come in, eat up the debris from the trabecular meshwork, which is what opens it up and reduces the pressure in the eye. From a practice point of view, we've kind of long known that it works much better if it's used as a first-line treatment. If the patient has been using topical medication for some time, it's not as effective. And the feeling is because the morphology of the trabecular meshwork changes when it's been soaked in drops for a long period of time. So that's why it's now been recommended as a first-line treatment. Pigment dispersion syndrome, only because you do actually have pigment there and you see it firing away, there's a higher risk of having IOP spike post SLT. So the recommendation, either you only treat 180 degrees instead of standard 360, see how they respond, and if required, you can treat the second 180 degrees at another visit. But most of the time, if it's something that you keep in consideration when you do the treatment, is usually absolutely fine. It works 90% of the time. It doesn't last forever because you get the build-up coming back again. So we know really, again, in real life, it probably is effective for a period between 2 to 3 years. It is repeatable, but the efficacy wears off with every single try. So then usually after the third round of SLT, the feeling is you're not getting that much IOP reduction for a long period of time, longer enough period of time. So then people stop repeating it after 3 times. The safety profile is very high. There's really low risk to the treatment itself. The biggest risk being that it may not work, and sometimes in some patients it doesn't work, even if you target the right tissue. There has been some documentation of very inflamed angles afterwards and seeing some inflammatory material in the AC. And that might be due to the fact that somebody just used very high energy when they were doing the actual laser. There's been some evidence of peripheral anterior synuclei noted at the drainage angle post SLT, again for the same reason. IOP spike, which tends to be transient, very rarely it stays up and then you can't bring it back down again. There's evidence of the inflammation going posteriorly, so you get a bit of CMA or corneal changes. But again, all these things are very, very unlikely to happen. So that's the SLT. When it comes to narrow angles or primary angle closure, again, the treatment for that has changed based on 2 trials that I wanted to touch on today, namely the EAGLE trial and the ZAP trial. So the EAGLE trial, which is older than the ZAP, essentially looked at patients with primary angle closure of pressures above 30, but actually healthy optic disc, and they were over the age of 50. And what they found, essentially what they looked at, is clear lens extraction. So essentially doing a cataract operation, but in patients who had a vision of 6/6 or better, versus the conventional treatment of peripheral iridotomy. And what they found is actually after 18 months, the clear lens extraction was superior. And that kind of makes sense when you think about the anatomy of angle closure in the first place. Because what you have is you have a very small eye with a structure that's growing, that being the natural lens. The peripheral iridotomy works by creating a pathway for the aqueous fluid in order to tamponade the iris diaphragm down to open up the drainage angle. But obviously after a period of time, the lens is so big that essentially it doesn't work. So then the angle closes up and then you have issues with it. So then that changed the recommendation. Anybody over the age of 50 with high pressures and a closed angle, they should have a clear lens extraction versus peripheral iridotomy. Then comes the ZAP trial, which basically looked at prophylactic treatment of laser iridotomy and ultimately trying to decide whether or not it is necessary in these patients. And although having a PI reduced the risk of angle closure by 47%, actually only 1 in 20 patients had it in the first place. So there is a very high percentage of people out there with narrow angles that basically remain completely asymptomatic for all their life. And the recommendation was from a cost effectiveness point of view, it really wasn't worth doing. So again, every time in the past 10 years, somebody presented with a narrow or closed angle, the recommendation was essentially they should have a peripheral iridotomy. So this is a prophylactic treatment, but 2 things that have to be noted. A, it's not without its own side effects that we will touch on in a minute. And B, having a patent peripheral iridotomy does not eliminate the risk of angle closure. It reduces it, but doesn't eliminate it completely. I've had a number of patients who presented later on in life after having a peripheral iridotomy with now essentially a growing cataract, who presented to A&E with angle closure. So that's just something to keep in mind. Now, the side effects of peripheral iridotomy range from mild, which is normally a mild inflammation post-laser, but that's expected because essentially you're creating a hole in the colored part of the eye. The eye becomes inflamed, red, uncomfortable, but usually a short period of time. There could be bleeding at the time of the laser procedure because a blood vessel was hit. Again, transient tends to settle down. The biggest one that does cause permanent disturbance is visual aberration, because the light goes through the laser hole if it's not placed in a location where the tear film doesn't affect the refraction of the light. And that can be quite troublesome, especially for a patient who essentially didn't have a problem before they had the treatment. So now kind of peripheral laser iridotomies are really, in terms of the prophylactic ones, are reserved for patients who say at the point of they're under 50, at the point of presentation, their pressure is high. There is evidence of iridocorneal contact in at least 50% of the drainage angle. They have had symptoms of subacute attack of angle closure. So that will be red, painful eye, especially at nighttime, halos around light, so on and so forth, or evident PAS when you go near the patient. Otherwise, the advice is you'll be absolutely fine. I would actually say wait until you have your cataract done, advise them on the symptoms and signs of angle closure, and leave them well alone. That's how the practice has changed when it comes to managing these patients. So if neither option of the laser is available and you need to require topical medication, which is a very reasonable option for a lot of cases and a lot of reasons. Now, prostaglandin analog is the first line treatment when it comes to all these patients. And the ideal situation would be to prescribe them preservative-free drops all the way through. And I'll touch on why that is. If for some reason they require more than a single agent because the disease is severe or not responding to a single agent, again, combining the medications together. So using a drug that has two drugs in it instead of one improves compliance because they don't have to use so many drops throughout the day, and therefore that helps with keeping the disease more at bay. So why preservative-free? You have all, I'm sure, seen these patients come to you in your practice. Preservative, or namely BAC, which is available in all the drug medication, causes allergies, chronic irritation, toxic reaction, as well as severely dry eyes. So then you end up having to give them substitute for the dry eyes that have been caused by the medication. From a glaucoma specialist point of view, we are very, very careful of the conjunctiva. If later on in life, God forbid, we will need to do some kind of filtration surgery, and we want to protect the eye and keep it as calm and as white as possible, because that improves the success rate of the filtration surgery later on. So that's why there's been a big push again in the last 5 to 10 years to, at the point of prescribing any medication, to prescribe only preservative-free drugs. The drug companies have also come on, with the exception of brimonidine family of drops. All the other medications are available preservative-free and by different makes, because I know there's been times where there's been shortages of medication, especially with Brexit, COVID, so on and so forth. But thankfully, there's always a plan B. So there's always another drug company that makes a beta blocker that's preservative-free, a prostaglandin analog that's preservative-free, so on and so forth. So I would definitely urge to get all patients on preservative-free medication to avoid them looking like the pictures that we have here, because in the long term, it is better for their quality of life, it is better for their quality of vision, and it is better for their glaucoma. In terms of topical therapy, there's quite a few exciting things coming on, some already in the market, namely the intracameral implants that I'll show you in just a minute. But there is this whole load of other things happening, whether it's injectable drugs, subconjunctival implants, punctal plugs, so on and so forth. But this one is already on the market, and that's the bimatoprost travoprost implant. So as you can see, you put it into the drainage angle, it's like a little sponge, and slowly it dissolves and releases drugs over 4 to 6 months period. It's interesting, it's exciting. I mean, to be fair, in the lifespan of a glaucoma patient that will hopefully live on for 20 plus years from the point of diagnosis, putting an implant every 6 months, I understand that we do it for medical retina, but at the moment, I think everybody's still watching the space when it comes to these slow release implants for their drops. So that is the topical medication. Now, what if topical medication is not enough or not an option? So again, you have patients that are either intolerant to all medication, including preservative-free. So it's actually the drug itself that they are sensitive to. They have health issues or issues with their hand and arthritis and physically can't put the drop in. They have dementia, they've got disease, they've got, social circumstances that doesn't allow for the use of drops, and then we have to go down the surgical route, or in most cases disease progression, and essentially topical medication is not enough. Conventionally, the main bread and butter of glaucoma surgeons is essentially a trabeculectomy, and what you're doing is creating a partial thickness flap in the sclera and allowing for the fluid to communicate between the anterior chamber, and then you will develop a bleb for the conjunctiva that overlies the flap for the fluid to drain through. So in nice eyes, this is what it looks like. There's been a big push to use the more field-safe surgery technique, where essentially the flap door will be under here somewhere. You've got your peripheral iridotomy here, or iridectomy, that you've had to fashion to create the channel to communicate between the anterior chamber and this new space that you've created. You put these releasable sutures in that you can adjust and manipulate in order to control the pressure better. We use anti-scarring agents like mitomycin C, lots and lots of preservative-free topical drops for 6 to 8 weeks, and then hopefully it looks like that. Success rate is 95%. It does scar down because essentially you're making a hole in the eye, and naturally the body wants to close it, and the failure rate is about 5% per year. So the lifespan of a trabeculectomy is between 10 to 15 years, maybe a little bit longer depending on the patient that you have operated on, and essentially the quality of the bleb and the surgery from the word go. Unfortunately, a lot of them end up looking like this. So there's a lot of scarring. You've got the ring of steel, which then causes thinning of this bleb. Blebs can leak, cause infection. You can get bleb dysesthesia, so on and so forth. So it's not for everybody. There is a big commitment anyway at the beginning to get to this stage, because the patient has to come and see you fairly regularly, usually day 1, week 2, week 4, week 6. So there's a lot of pressure and a lot of manipulation. So therefore it's not for everybody. And like I said, they use intensive topical steroid for that period of time. The drops are going in every 1 to 2 hours. So what would be an alternative? A tube implant. Essentially, from a glaucoma point of view, that's usually the end of the road. So these are the big tubes. The tube is quite large, sits inside the anterior chamber, goes back about 10 millimeters, and essentially it drains onto a plate. So it's not bleb related in terms of the filtration. You can see the tube in the anterior chamber here. As you can see as well, this patient's had previous surgeries before, whether it's peripheral iridotomy from a laser point of view or a scarred down bleb, probably one or the other. Again, very successful, but very volatile. The control of the flow through that tube is quite tricky. So you can either have too much or too little. Too much, the pressure stays high. Too little, the eye becomes hypotenuse and very difficult to manage. So again, it's put as a last resort, not a first one. So that's kind of led to us trying to think outside the box and moving forward and going back to the point that we were discussing about patient expectations and life expectancy, to try and start little and work our way to the top and not just simply have the filtration surgery as one option. So that led to the creation of MIGS, or minimally invasive glaucoma surgery. So these are small, tiny implants that can either be as a standalone procedure or combined with cataract surgery. They give you moderate IOP reduction, 30 to 40%, and they have a high safety profile. Most of them tend to work on the outflow, but not all, and I will demonstrate. The oldest one that's been on the market for the longest is the iStent. That's been through a number of generational changes since it's come on the market. It's also the one that has been worked up by NICE. So we do have some protocol with it. Essentially, it's a titanium. It's now preloaded into an injector. It is the smallest implant in the body, 360 microns in size, and it goes into the trabecular meshwork to reduce the resistance of the outflow, and it goes into the collector channels. The future of that is still, again, working. is iStent Infinity and iStent Supra. I think there's a bit of hold on that one, but the Infinity, there are 3 preloaded stents in the injector. This is how small it is. And this is what it looks like once it goes inside the eye. Thought you guys might be interested in watching video of the implant. So again, this is done in theatre. Some people do it at the beginning of cataract surgery. Some people do it at the end. This is a direct gonioscopy. So this is direct gonioscopic lens. This is the injector or the introducer. And essentially, as you can see, you're aiming for the trabecular meshwork. Sorry, should have zoomed in a little bit more. And you're just trying to get into the right position and line it up. Ideally, you want the stents to be about 2 to 4 clock hours between each other. It just increases your chances of hitting collector channels. Blood reflux is a very good sign, because usually what's happened is, especially if you do the surgery at the end of cataract operation, which is what I do, the pressure in the eye has been raised. So if you hit an area where there are collector channels lying behind the eye stent, essentially you get the reflux of blood coming back. When we first started doing these, we were putting vision blue in the eye, and you can actually see it going through the episcleral vessels as well, which is quite exciting. And you've got 2 very lovely stents sitting in the drainage angle. Very pretty. Takes 5 minutes at the end of cataract operation. Like I said, it does reduce pressure by 30 to 40%. There are quite a few other variation of MIGs, namely you've got the hydrus, same principle again, just opens up or scaffolding within the trabecular meshwork. It is much bigger in size. The efficacy, again, you can speak to different reps, they'll tell you different answers. You know, some studies show that the hydrus is more effective than the iStent. Other studies show otherwise. Again, personal choice. And the Omni, which is the only non-implant MIGS. And that works on the principle that you do viscodissection, and then you put this nice plastic tube all the way in, and then you pull off the roof of the trabecular meshwork. I think it's been around for about a year, maybe a bit longer. Again, I think with these things, all of us have agreed from a glaucoma point of view, find one that you like and stick with it, because ultimately the principle is the same in terms of targeting the outflow and increasing the fluid coming out of the eye. So it's whatever's comfortable, it pretty much will work on the same principle. Now, the one that doesn't quite work the same is ECP, or endocyclophotocoagulation. So that's exactly the same frequency as a diode laser, but it's direct in the sense that you visualize the ciliary body, and therefore it is safer, it's more controlled. You're less likely to get the hypotony that you can get from over treatment, and it works by turning the tap off, essentially, instead of targeting the outflow. Again, thought it'd be quite fun to watch a video of one of these. So that's actually ciliary body. So the device is actually loaded up on a camera. You've got the screen, you've got the laser beam. You can see the ciliary processes, and then actually what I thought would be quite fun is that's the suspensory ligaments off which the lens is usually suspended. Like, quite fun to see. As you can see, you blanch them as you go around, and you can do about 200 degrees just from your main incision. If you want to do 360, you can make another incision, turn around and do it onto the other side. Again, very effective, but can be quite inflammatory because you are actually causing tissue destruction. So those patients will need to be on intensive steroids afterwards. Now, if that's not enough and you need a bigger IOP reduction, but you don't think the patient will cope with the changes with trabeculectomy, a PreserFlow is an in-between house. So again, it's, instead of creating the big flat door, you just stick a plastic tube in, and then it also creates this reservoir that goes underneath the conjunctiva, and you do get a bleb with it. It's a much quicker operation. So when we first started doing it, it was during COVID. So we're doing double number of cases of theatre time. So essentially it was very promising. It's very effective in the right people, but I think there is a study right now looking at the efficacy of PreserFlow versus TRAB, and with the patients that have high risk of scarring, the feeling is it may not be the best option because you've got much slower flow rate here in comparison to a big flap door. So might not be an option. And from a tube implant point of view, because the biggest risk factor being hypotony, there's been some modifications of that, one of them being the Paul tube. So the lumen is a lot smaller, so much lower risk of hypotony, but you still get the same size of the plate. So theoretically, you should get the same IOP reduction. And another exciting one, excuse me, is the eye plate. So similar kind of design in terms of the implant, but does have a magnet that you then can attach either on the other side of the eye or externally to try and essentially dial the pressure up and down. At the moment, it's still in its infancy, so watch this space. And the last one, which is exciting, is the superciliary space. So that's not subconjunctival or MIGS. And essentially what you're doing is creating a cleft and allowing the fluid to escape through that. And that's a mini eject. There was a similar one called the SidePass many years back, but it was taken off the market. So now the mini eject has come in to try and see if it will be just as effective as the SidePass was. And you can see it here in the drainage angle, obviously much bigger than a MIGS. Better IOP reduction, there's about 18 months to 2 years worth of data in terms of efficacy. It seems to be working about 75%, 80% of the time. So it'll be interesting to see how it copes over the next couple of years. The last thing that I wanted to touch on is the micropulse diode. That's sort of like an SLT done externally. So it works by, again, affecting the trabecular meshwork and stretching the tissues out instead of targeting the ciliary body. So NICE has looked at the fact that even though it's safe, the efficacy is questionable. So at the moment, it's only being used in trial setting, but watch the space because it probably will be more readily available on the market because of the safety profile being high. And obviously the standard cyclophotocoagulation done transclerally. So just like with this picture, a probe is applied externally onto the eye to try and target the ciliary body without physically going inside the eye. Obviously, you're doing it blindly, so you can undertreat or overtreat. The machines are getting better in terms of the settings and safety profile, so you are less likely to overtreat, but that does mean sometimes there's undertreatment and it needs to be repeated, but that's easier to control than very low pressures. And what's next in the future? There will be a lot of MIGS refinement, as you saw with the eye stent, and I think the rest of them will undergo the same kind of changes. And the big thing is gene therapy. So it's optic nerve regeneration. So not only will we halt progression of the disease, but we'll be able to offer reversing damage that's already been established. And that will be very, very exciting once it comes into play. And that's all I had to say, if that's okay. Happy to take questions. I'll stop sharing my screen.
Thank you very much for that. That was really interesting. It's interesting what you were saying about the new developments, because obviously you work in London and we're based in on the south coast in East Sussex, and I think our trust is quite proactive with our consultants, because myself and a number of optometrists and an orthoptist, we do SLT.
Oh, great.
We train to do SLT, and we do SLT on patients. So it's really interesting. And about the MIGS, our consultants are often talking about MIGS, and we have teaching with them. And preservative-free drops as well. We are getting that drilled into us from our consultant that all drops should be preservative-free. So it's really interesting hearing your talk about what you do in London as well, and we're doing the same.
I've just forgotten, there's one thing. Have you heard about the DSLT that's coming in?
No.
Oh, that's exciting. That's already been in the market. I've played around with one of the machines. Essentially, it's done without the lens. So it's all done externally. It's almost like the excimer laser that gets used with the LASIK or the refractive laser surgery. You have to put a clip inside the patient's eye so the eye can stay open, lots of topical medication, and it does a mapping, and essentially it goes zoop and zaps it in about 10 seconds.
Really?
Yeah.
That's interesting, because I had a patient today who had really tiny, narrow apertures, and I really struggled to get the lens in place. I managed it in the end, but it wasn't pleasant.
Yeah, sorry. So yeah, DSLT is definitely coming. There's lots of trials to try. So again, they've only got about a year's worth of data in terms of efficacy. It seems to work just the same as the standard SLT that we have. It is a different frequency because obviously it has to penetrate the sclera to hit the ciliary, to hit the trabecular meshwork, as opposed to when you do it, where you're directly applying the laser onto the trabecular meshwork. Again, watch the space, but obviously if it proves to be as effective,
that could be the next thing.
It would be the next thing. We like toys and glaucoma, basically. I think that's it. I think that's a take-home message from my talk.
That was a really interesting talk. I really enjoyed that. Thank you very much. So we do have a number of questions. So if you are ready.
Yep.
So the first question, can there be debris, e.g. from pseudoexfoliation in the angle without precipitating glaucoma?
Yes, you can. So you basically classically get something, there's Samplini's line that you get with pseudoexfoliation. The risk of conversion of pseudoexfoliation syndrome to pseudoexfoliation glaucoma is higher. So it's about 50% with patients with PXF convert to glaucoma, whereas with pigment dispersion, only 25% of them convert to glaucoma. We don't know, but I think only because with pseudoexfoliation, it's not just the angle where the deposits are sitting. They're also sitting on the ciliary body, they're sitting on the fibers, they're sitting on the lens capsule, they're sitting everywhere. Whereas with PDS, they're really only sitting in the angle, and then obviously you've got a little bit of debris sitting on the cornea. But the answer to the question, yes, you can have all the signs, but no actual glaucoma. It's just one of the risk factors. If you have it, then your chances of getting glaucoma within your lifetime will be higher than the general population.
Yeah. Thank you very much. So another question. We used to see peripheral iridotomies at 12 o'clock.
Yeah.
But these days we see them more done at 3 and 9 o'clock. Is there a good reason for this?
There is a very good reason for this. I was going to talk about it, but then I thought maybe you guys don't want to know this. Moorfields did a study that looked at the chances of getting the aberrations in the vision based on the location of the PI. And interestingly, they found when you completely expose it at 3 and 9 o'clock, because it's not being affected by the tear meniscus. So the issue is not whether or not it's covered by the lid. What they identified the issue being is actually the angle between the lid and the PI and the tear meniscus. And if it's not 100% covered, even if it's a tiny little bit of a slither, then the light reflects through it. But weirdly, if you have it completely exposed, i.e. at 3 and 9 o'clock, then they get no visual aberration. But that's the case. The only problem is at 3 and 9 o'clock, that's where the neurovascular bundle comes in. So it's a lot more painful. So you have to warn the patient. It will be a lot more uncomfortable to have it done at that location, but much lower risk of getting the visual aberrations.
I do remember hearing a story about a patient who had PIs and then they ended up getting diplopia, double vision, and I think the trust had a bit of an issue. And
yeah, it's a nightmare to manage because, like I said, most of them are absolutely well with no problems at all, and we've done this to them, and then they're like, well, you know, it's difficult to manage.
What difference in the RNFL thinning would you classify as progression based on disco CT when there is no change in field defect?
Yeah, that's a tricky one, only because, and this is why I sort of like touched on it, because the thing with OCT is you can spend all day talking about it. The machines are still not clever enough to give you a vague idea, but roughly anything up to about 20 microns. So there's a natural progression anyway. So we all lose nerve fiber layer as we get older, the rate being about less than 5% annually. So I think anything above that, so if there is about a 10 to 15% reduction in OCT changes over a period of time that's less than a year, then that's considered substantial change. So it's more of a percentage thing as opposed to exact microns, because the machines measure it slightly differently. Do you see what I mean? So they're all calibrated slightly differently. And also the main issue with it, so the way it tells you whether you are quote normal or abnormal is based on the data, that the normative data that they have. Some of the machines have very small normative data cohort of about 50 patients. So of course, 90% of the population is going to be outside normal based, because so many of us are going to be different from that 50 patients that they have. Some machines haven't even declared the size of normative data. So that's why at the moment, the initial picture is fine, but what you're looking for is the change of that initial picture on that same machine, because that's the other thing to be careful of. The different machines will be calibrated differently. And if there is a more than 10% reduction in a period less than a year, then you worry.
So, because I do glaucoma clinics as well, what's the flooring effect, and how can you tell if you've got flooring effect of the disco CT?
No idea. It's a simple
flooring effect is where it gets to a certain level, isn't it? And then
once you get to 50 microns, it's got nothing to measure, so it's pointless. Yeah,
the effect is just
yeah. So once you've basically in the end stages is absolutely pointless doing a disc OCT, because again, it works on the fact that you need nerve fiber layer for you to measure. If you've got a cup disc ratio of 0.99, there's nothing to measure. It's just going to be red all the way through. It's not sensitive enough. But again, the OCT is changing, the frequency of light is changing. They are going to start measuring more and more things. So I think, again, as time goes on, it will be better at picking up changes, more subtle changes earlier, as well as in kind of picking up nerve fiber layer when it's there in the very advanced stages, but not right now.
How long do eye stents work for?
So there is recently been a 10-year paper published that shows it's still effective in about 85% of patients at 10 years. So it's definitely worth its money. Yeah. It's not cheap, but it's definitely worth its money.
Yeah. So if you decide to do a PI on a PAX patient and the patient does not require any further treatment, including drops, do you discharge them or follow up long term?
I discharge them.
If you discharge, when do you do this?
So usually we do the PI, we see them immediately afterwards, depending on the age of the patient. So I recently had a patient who was only 30 years old. I discharged them immediately after that. They had a very good optometrist that we had a direct communication. I advised them to carry on seeing the optometrist once a year. If there's any change or if he had any symptoms of angle closure, present to the nearest A&E. An older patient, so say someone who's in their late 40s, I probably want to watch them just a little bit more because of the effect of the actual natural lens at that point if they're still phakic. So maybe do the PI, see them, excuse me, immediately post laser 4 to 6 weeks to make sure it's effective. See them maybe one more time, about 6 to 9 months, and ideally have serial anterior segment OCT so you can measure to see if there's been any change in the angle in that period of time. And if it looks like it's opened after the PI and remained open for at least a year, then that's absolutely fine.
Thank you. Is it safer to do a PI before cataract surgery? And is cataract surgery more difficult or risky if a small eye narrow angle without PI?
So I think, again, this is where the EAGLE trial plays a part. And normally when I have these patients coming in, if it's purely a narrow angle without any evidence of no history of angle closure symptoms in the past, when you go near them, more than 50% of the angles open, narrow but open, normal pressures, healthy disc, I actually do nothing to these patients at all. I send them back to the optometrist and tell them, you're absolutely fine, go away, we don't need to do anything. If you think, no, they need something, i.e. the pressure's high, the angle's closed, evidence of PAS, etc., and they are over the age of 50, we go straight for lens extraction. There is no point doing a PI, and that's what the EAGLE study has shown at this point. Doing the PI, if anything, makes the cataract surgery trickier because the process itself, A, it's inflammatory, so it can cause peripheral anterior synechiae. It can disrupt the zonules, so it makes the lens less stable. And it doesn't help in any other way in terms of the procedure itself. Doing cataract surgery in small eyes is tricky anyway because you've got much less space to operate in, but that's why most of the time they're done by people like me who essentially, this is what we do day in and day out. So we're so used to doing these angles. And the small eyes, it's just part and parcel of the day-to-day practice. If it's someone that doesn't do them all the time, then they have to take extra steps and precautions to make sure they don't run into trouble. But that's kind of like the sequence of events.
Yeah, thank you. What percentage of PI patients develop glaucoma, and is a full aperture scar low risk?
What's a full aperture scar? Oh, the thingy closing. I think probably the PI closing. It is a low risk, irrelevant of the size of the PI, funnily enough. It's, it's if it's an inflammatory eye, so say if it's a brown iris that you've had to use quite a lot of high energy, then obviously the inflammatory process will then close up the actual PI in the first place. What was the first question again? Sorry, I completely the beginning.
Sorry. It's what percentage of PI patients develop glaucoma?
Oh, very little, but then it goes back to the point of why the ZAP trial was very important, because it showed actually quite a lot of them, nothing happens to them within their lifetime. 85% of these patients wander around in their life with their nice, healthy eyes with no problems whatsoever. So that's the whole point. The PI is irrelevant to the disease in a way, if that makes sense. So now the recommendation, because it's changed completely in terms of who we're offering to. So like I said, 10 years ago, everybody with a narrow angle got a PI. That is definitely not the case anymore. You would have to actually have symptoms of the disease. So either high pressure, that puts you at risk of getting glaucoma anyway, signs of peripheral anterior synuclei, half of your angles closed, your pressure is going to go up, that's going to give you glaucoma, previous symptoms of subacute attacks. So the cohort of patients that are being treated is completely different. So therefore, the percentage of those patients will have a higher chance of getting glaucoma because they're already at a high risk anyway. Does that make sense? Whereas 10 years ago, we were treating everybody and anybody, and actually we were over treating people. That's what the study has shown us, for no reason whatsoever.
Yeah. Any hints on examining myopic discs for glaucoma?
Oh no, none. Sorry. Repetition. I think basically, and normally what I tell these patients is, your eyes look different because you're short-sighted. What you're looking for is progression. We go back to the point of this progression. So then you say, well, the question is it different because you're short-sighted, or is it different because actually there's evidence of disease? And the only way to tell is you look for progression. So you do an ACT, or you can even do an optos and take a picture of the disc, bring them back in another 6 to 9 months, repeat it again, bring them back in a year's time if everything's stable, and then you've got 18 months to 2 years worth of data of them looking different than the rest of the world, but normal to themselves. That's the safest way to do it.
So quite a good question here. For OCT, do you use ganglion cell complex measurements as opposed to RNFL analysis?
Yes, because ultimately the RNFL analysis is looking at the death of the ganglion cells, which happens at the macula. So that's what I mean. Like, we can have a whole talk about OCTs. If you speak to the main guys that do all the studies that look ACT, it's all about the ganglion cell complex. And there's another thing which I can never remember that they always show me, the different maps of what you're, because that's what's dying, is the ganglion cells that are dying, the highest concentration being at the fovea within the macula. So that's a bit that's more interesting, even though we're all fixated about looking at those circles of the disc. The circles of the disc mean absolutely nothing to them. They completely ignore it. But again, I think as we become more informed about the OCT, the use of OCT, and how it's ultimately applicable to assessing these patients, as well as disease progression, as opposed to the efficacy of the treatment, will get better and better. To give you an example, one of the new OCT modes that's going to come in is going to be intraoperative. So it helps us look at the drainage angle, identify where the collector channels are going to be, and put the stent exactly there. That's coming. So there is a lot to say about how this is changing and how we are going to use these scans to interpret the results properly. But yes, ganglion cells, definitely.
So you just said there, that's a whole new talk on OCTs. Maybe that's something we could do in the future.
Yeah, yeah, they're not my big thing. I had to give one recently, and then, to be fair, I had to go speak to people to make sure we get all the information right. But yeah, OCTs are very interesting. There's a lot more to them than there is out there right now, and they'll get better, definitely, no doubt.
So if you have a patient who is symptom-free and stable on a generic prostaglandin analog, would you always switch them to preservative-free drops?
Ideally, yes, but it doesn't always happen. I saw exactly that patient yesterday who's 81 years old. She's been on this drop for 8 years. She's like, I'm really happy, leave me alone. And you're like, okay. It's a discussion to have with the patient, that's because we get asked the same question. What about a patient that's already been on topical medication? Would you offer them SLT? You would, but will they take it? A lot of them will say to you, listen, I'm in the habit, the drop is next to my bed, I put the drop in my eye before I go to sleep, I'm absolutely fine. Which is why it was interesting when they looked at the quality of life measures of SLT versus drops. You would think the SLT group will be a lot happier, but actually they weren't. It was exactly the same.
Yeah. How would you differentiate between optic disc neuropathy from glaucoma and disc atrophy caused by hypoperfusion or caused by fluctuations of blood pressure?
So that's normal pressure glaucoma, which is ultimately the same thing, if you know what I mean. From my point of view, it's ultimately the same disease. So with normal pressure glaucoma, what happens with these patients is they have quote unquote normal intraocular pressures, but poor perfusion to the optic nerve head. And usually what happens, especially at nighttime, the pressure gradient between their intraocular pressure and perfusion pressure changes to the point that essentially the circulation gets squashed. No blood comes to the optic nerve head and the optic nerve dies. ultimately it is still a progressive neuropathy. So even though it's a different disease pathology altogether, it's still giving the same picture of the optic nerve dying and causing a corresponding visual field defect. Apart from, which we do this all the time, writing back to the GP and say, please do 24-hour blood pressure monitoring, make sure this patient isn't being killed daily by giving them too much medication and causing nocturnal dips at night, you still try and lower the eye pressure as low as possible so you don't have that episode of hypoperfusion that causes the nerve death. There's nothing else that you can do. Some of them just naturally have very low blood pressures. They're very difficult to manage.
So is it best practice to use a 78D Volk for CD?
Yeah, I mean, I've got a Super 66 because it's just 1-to-1 ratio, so it's just a lot easier.
Yeah.
Instead of a 90.
And would you ask for a head scan in long-standing glaucoma patients?
Not if there's no reason, then not if everything ties in together. So normal pressure patients at point of diagnosis, we tend to ask for a CT just to basically make sure there's no intracranial pathology that's causing the optic nerve changes. So if the pressure is normal, everything else seems a bit fine, and you can't really identify any other cause, then you can do it. But if it's a very simple picture of high pressure and optic nerve damage with a visual field defect, there's no need. One of the times that we do it is if you have progression, despite the pressure being within your quote unquote target pressures. Again, we do imaging just to make sure we're not missing anything else. But unfortunately, a lot of the time with these patients, once they've hit the slope of progression, we're chasing lower and lower pressures. That's actually what's happening because the nerve is sicker, so it's more sensitive to these pressures. So whereas a healthy nerve can tolerate a pressure of 20 to 25, a CD ratio of 0.995, where they've lost 75% to 80% of the nerve fibers, it just can't tolerate it anymore. So it just becomes more brittle and more sensitive to these changes.
Perfect. That is all the questions. So thank you very much.
Pleasure.
So,
pleasure.
Thank you everybody for watching tonight, and thank you, Sally, for that amazing talk. Hopefully I'll try and ask you to come back and do another talk again in the future. I will get the certificates out, not this weekend because I'm away, but next week I will email you all with your certificates if you have logged on and watched for the duration of the webinar. Please keep an eye out for future webinars. We have got more plans, so I'll be advertising those when they're set up. But thank you all again for watching. Hope you stay safe. And I think there's just one more question. Oh, thank you very much, it says so.
Pleasure. That's a pleasure.
So, thank you all. Take care. Thank you. Bye-bye.